Good afternoon. Our presentation is called AVNEM, Addressing Vaccinations in New and Expecting Mothers. Our group members are Hokanson, William Spears, Paige Vigmostad, Krysta Norby, Jenna Bergmark, and Diana Rajabi. Our main goal of AVNEM is to increase the overall prevalence of vaccinations in San Diego County among the children of new and expecting mothers. Our priority population is new and expecting mothers and parents in San Diego County. Our objectives include the following. By the end of our intervention, 80% of parents will be able to list 3 vaccine-preventable diseases. Parents will be educated thoroughly on how many lives are lost to vaccine-preventable diseases each year, which includes 5 seconds a child dies from vaccine-preventable disease. By the end of our intervention, 25% of mothers will begin to vaccinate their children. By the end of our intervention, rates of vaccinations across San Diego County will increase by 25%. Our evaluation questions include the following. Did our intervention encourage more mothers to vaccinate their children who wouldn't have otherwise? How many mothers who were involved in our intervention experienced an increase in vaccination education? Was there an overall increase in the number of vaccines given as compared to previous years? And are mothers who attended our educational sessions at health clinics more likely to vaccinate their children than those who did not? Our conceptual model is based off of the health belief model, which includes perceived susceptibility and perceived seriousness, leading to a perceived threat, and perceived benefits and perceived barriers leading to an outcome expectation or a cue to action. That and a perceived threat lead to our overall goal of vaccinating children. We will be taking survey measurements before the study and at the end of the study. We will be using quasi-experimental pre-test post-test. We will be using the quasi-experimental design because we will not be doing random assignment to the groups. We will be comparing the rates of vaccines in elementary school students that we go to versus the elementary school students that we did not go to, and we will be working on a generous budget. We will be comparing the mothers that we educated to the mothers that we did not educate, as shown below. We will be using a convenient sample due to the fact that we are unable to randomize, and it will be the easiest way to reach our population. It is also very cost effective. Our target population is new and expecting mothers in San Diego County who have yet to vaccinate their children. Our frame is new or expecting mothers in San Diego County, and our sample is those mothers who agree to participate in AVNEM. Our dependent variable is increasing prevalence of child vaccinations in San Diego County. Our independent variables include current vaccination stigmas and knowledge of benefits and risks of vaccinations, as well as cultural competence. Our univariate is what is the number of vaccinated children in San Diego. Our bivariate is education in classrooms or pamphlets more effective in increasing knowledge on vaccinations. Our null is that there is no increased knowledge between education in classrooms and pamphlets. Our alternative hypothesis is that there is an increased knowledge through educating parents in classroom settings and handing out pamphlets. A multivariate variable is can the number of vaccinated children in San Diego County be predicted by income, geographical area, and culture. Our pretest is surveying before the intervention, and our post-test is surveying after the intervention. This is the data that we took from 1,500 new and expecting mothers in San Diego County. We asked the mothers whether they did or did not vaccinate their children, or if they were planning on vaccinating their children. We took the data once a year for 6 years. As you can see, there was a dip in the data in 2011 and a spike in vaccines in 2015. This will be explained in the following chart. This is a graph of the data on the previous slide. The first arrow points to the dip in the number of vaccines due to the rumors started about vaccines in 2011. Once everyone thought that the vaccines were causing autism and other side effects, they stopped vaccinating. From this moment on, there was a steady increase in vaccinations due to these rumors being proven wrong. In 2015, there was another major turning point which occurred from our public health implementation. We took the 2015 data after we implemented our public health program for 6 months. At the beginning of our intervention, 30 mothers who were given education materials or attended an education session were selected to take a test with questions about vaccinations. Of those people, 8% got all the answers correct, 42% got at least half correct, and 50% got less than half of the questions correct. After they received our intervention or education materials, 75% answered all of the questions correct. 25% got at least half correct, and only 2% got less than half of the questions correct. This tells us that our education portion was effective. Here are our results. At the start of our intervention, 22% of women involved in our intervention were not planning on getting their child vaccinated. By the end of our intervention, only 3% were still planning on not vaccinating their child. Beginning our intervention, 88% of new and expecting mothers answered all questions correctly on our health education survey, while after our intervention, this percentage increased by 65% for a total of 73% correct. This shows that our intervention increased overall immunization knowledge. As compared to 2010 to 2014, 2015 showed a 12% increase in vaccinations given to children. 45% of new and expecting mothers who attended our educational sessions at health clinics were more likely to vaccinate their child than those who did not. Although our intervention did show an increase in prevalence of vaccinating children, there are limitations to our findings. Overall, there will still be some mothers who do not want to vaccinate their children for some of the following reasons: socioeconomic status, cultural beliefs and stigmas, personal experience, and attention to social media. We know that it is a broad statement to say that our prevalence has actually increased in vaccinations since our sample size is about 1,500 children. Thank you and have a good afternoon.